Welcome back to the Deep Dive, the show where we take your stack of information, could be articles, research, maybe even just your own curious notes, and really distill it down into crystal clear understanding. Our mission, to give you that powerful shortcut to being truly well informed, complete with those surprising insights and, those genuine aha moments. Today, we're embarking on a truly fascinating and incredibly detailed deep dive. We're getting into the world of muscarinic receptors and the powerful drugs that interact with them. Now, this isn't just some niche topic, it's really a foundational pillar of pharmacology, absolutely essential for understanding how our bodies work at a fundamental level, and importantly, how many crucial medications actually achieve their remarkable effects.
Indeed, it really is. It's a subject that underpins so much of our knowledge about the nervous system and how medicines interact with our biology. What's truly fascinating here, I think, is observing how even seemingly tiny molecular differences, maybe in the receptors themselves or in the drugs targeting them, can lead to profound, really widespread effects across the entire body. We're talking impacting everything from your heart rate to your vision, even your memory. So today, we're going to pull apart the intricate details of how these receptors function, explore what happens when they're activated or maybe blocked, and really delve into the wide range of therapeutic uses and, let's be honest, the significant challenges associated with these powerful compounds. Our goal is for you to walk away with a truly master-level understanding, the kind the elite professionals in this field possess.
That's right. You've asked for a deep dive that equips you with that kind of comprehensive grasp. So we're leaving no stone unturned here, but we'll also make sure it's distilled into actionable, insightful knowledge for you. We'll start with the very fundamental nature of acetylcholine, the body's natural signal. They will move to its receptors, how we even discover them, their sophisticated structures, and finally, the remarkable, often quite clever ways drugs have been designed to target them. Get ready to gain a comprehensive, yet entirely digestible understanding of muscarinic receptor pharmacology. Okay, let's unpack this foundational concept first. Our journey really begins with acetylcholine, or AWAY, which is, as you said, a truly fundamental neurotransmitter in our bodies. So to kick us off, what exactly are these muscarinic receptors and where do we typically find them?
Okay, think of muscarinic acetylcholine receptors as critical communication hubs. They're primarily located on what we call autonomic effector cells. Now, these are the cells that respond to nerve impulses, specifically those coming from your postganglionic parasympathetic nerves. In simpler terms, these receptors are the primary targets for the rest and digest part of your nervous system. When your body's calming down, maybe processing food or recovering. Now, the name muscarinic itself actually comes from a really interesting historical discovery. Scientists back in the day observed that an alkaloid called muscarine, which, by the way, is found in certain poisonous mushrooms, notably Amanita muscaria, you might know it, the classic red cap with white spots
Oh,
mushroom.
right, the fly agaric.
Exactly. They found that muscarine acted selectively at these exact sites, and when it bound, it produced the same qualitative effects as acetylcholine itself. So to this day, the actions of drugs at these specific sites are called muscarinic, or sometimes parasympathomimetic, because they essentially mimic those rest and digest effects that etchy naturally mediates.
That's a great piece of historical context, really grounds the name. So while we often associate rest and digest with the parasympathetic system, the sources also mention that these receptors aren't just in those main areas, right? There are some perhaps unexpected locations. What does that tell us?
Absolutely. The body is always more complex than our initial classifications might suggest, isn't it? Muscarinic receptors are also present in what we call autonomic ganglia, which are clusters of nerves. And interestingly, even on some cells that maybe paradoxically receive very little or even no direct cholinergic innervation, meaning there isn't a direct nerve fiber reaching them to release Ashi, a prime example of this paradox. Vascular endothelial cells, those cells forming the inner lining of your blood vessels.
Hmm. Okay. So why are they there if there's no direct nerve?
That's the million-dollar question researchers are still exploring. In the autonomic ganglia and the adrenal medulla, their primary function isn't direct action, but rather to modulate the nicotinic actions of HEG. Without getting too deep into nicotinic receptors today, there are another class of HH receptors, and the muscarinic ones here sort of fine-tune their activity. This phenomenon, where receptors are present with little direct nerve input, it points to a much more complex, maybe more diffuse signaling environment than just simple direct innervation would imply. Perhaps there's local spillover of HE or other mechanisms we don't fully understand yet. And here's where it gets really interesting for your brain. In the central nervous system, the CNS, muscarinic receptors, are incredibly widespread. They play a crucial role in mediating many vital responses. Areas like the hippocampus, which is your memory center, the cortex for higher level thought, and the striatum, crucial for movement control, all have particularly high densities of these receptors. So their influence extends far beyond just basic rest and digest functions. They're deeply involved in how you think, how you move, how you remember.
That sounds incredibly important for brain function. But if HE is this fundamental natural neurotransmitter, why isn't it used widely as a therapeutic drug itself?
Yeah.
It seems like it would be the obvious, most natural choice if someone needed more of its effects. What's the catch?
That's a critical question, and it highlights a fundamental challenge in drug design. Mimicking nature isn't always straightforward, is it? AKH, the naturally occurring neurotransmitter, has virtually no systemic therapeutic applications. And the reason is actually twofold and quite practical.
Right.
First, its actions are incredibly diffuse. Think of it like a shotgun blast rather than a precise laser beam. HE acts everywhere there are muscarinic receptors and even on some nicotinic receptors too. So if you administered it systemically, you couldn't target a specific effect, let's say to stimulate bladder function, without causing widespread, often undesirable issues across the entire body. Heart, salivary glands, you name it.
You're too messy.
Exactly. And second, perhaps even more importantly from a practical drug perspective, its hydrolysis, its breakdown by enzymes, is extremely rapid. It's quickly broken down by two key enzymes, acetylcholinesterase, or ACE, which is a major one, and also plasma butyrylcholinesterase. This rapid hydrolysis means it has a very, very short half-life in the body. We're talking seconds, maybe a minute or two at most. It disappears almost as quickly as you administer it.
Wow, okay.
Plus, its penetration into the central nervous system is very limited, and the amount that even reaches peripheral areas with low blood flow is negligible, again, largely due to that rapid hydrolysis. So this inherent instability and that lack of selectivity makes it unsuitable for most systemic therapies. And this is precisely why pharmacologists have had to design specific drugs that can overcome these natural limitations.
So, if nature's own AC is too broad and frankly too fleeting to be a useful drug, how did scientists even begin to understand these receptors well enough to design effective medications? I hear the source material talks about an evolution from that initial characterization you mentioned to something called molecular cloning that really changed everything. Could you walk us through that journey of discovery?
Sure. The initial characterization of these receptors was, quite clever for its time, especially considering the limited tools scientists had back then. In the early days, researchers primarily analyzed the responses of cells and organ systems, both in the periphery and the CNS, to different chemical compounds. They were essentially observing what happened when they applied various substances and trying to categorize the effects. For instance, the different effects of two specific muscarinic agonists, bethanechol and Mecane 343, on things like the lower esophageal sphincter muscle, led to that initial designation of muscarinic receptors as M1, found mostly in autonomic ganglia, and M2, thought to be on effector cells elsewhere. That designation happened back in 1978, and it was a significant step forward, providing a basic framework for understanding.
But still pretty simplified, right? Just two types.
Exactly. But here's where it gets really interesting, and our understanding just exploded. This two-subtype concept was dramatically supplanted by information obtained through molecular cloning in 1987. This revolutionary technique allowed scientists to identify not just 2, but 5 distinct gene products. These are now officially designated as M1 through M5 muscarinic receptors.
5.
5. This literally changed our understanding almost overnight. We moved from 2 functionally defined types to 5 genetically distinct and structurally characterized subtypes. It opened up a whole new realm of possibilities for much more targeted drug development. It's like discovering there aren't just 2 types of light switches in your house, but 5, and each one controls something slightly different.
5 different types. That's definitely more complicated than 2.
Yeah.
What does that mean for how they actually work inside our cells? How do these 5 different types translate a signal from a drug or from a sheet into a cellular response? Can't just be a simple on-off switch, can it?
You're absolutely right. It's far from a simple switch. That's the beauty and the complexity of G protein coupled receptors, or GPCRs, which all 5 muscarinic receptors belong to. They're called GPCRs because they're intimately coupled to these things called heterotrimeric G proteins located right inside the cell membrane. These G proteins then act as critical relay systems, interacting with various cellular effectors to translate that external signal into an internal cellular response.
Okay, so they pass the message along.
Precisely. And while the selectivity isn't absolute, there's a clear and rather elegant pattern in how these 5 subtypes signal. Stimulation of M1, M3, and M5 receptors primarily activates what we call GQ proteins. Right. This triggers a complex cascade involving an enzyme called phospholipase C, or PLC. Think of PLC as like molecular scissors that cut a specific lipid called PIP2. This cutting action then mobilizes calcium ions, CaA2 plus A, from internal stores within the cell, and it also activates another enzyme called protein kinase C. These actions lead to a wide variety of cellular responses, often associated with key functions like smooth muscle contraction or glandular secretion, think salivary glands or gut muscles contracting.
Okay, so M1, M3, M5 tend towards contra or secretion via GQ. What about M2 and M4?
Good question. In contrast, M2 and M4 muscarinic receptors operate on a different pathway. They inhibit an enzyme called adenyl cyclase, which normally produces cyclic AMP, another crucial intracellular messenger. They also directly regulate specific ion channels. They do this via their coupling to a different set of G proteins, specifically G and GO, which happen to be sensitive to pertussis toxin, the toxin from whooping cough, actually. The elegance of this system is that these different G protein couplings allow for diverse downstream effects from a single class of receptors, all depending on which subtype gets activated. And here's the really cutting-edge part. Recent cryo-electron microscopy studies have provided incredible high-resolution images. They're revealing the precise structural basis underlying these G protein coupling preferences. It's like getting a molecular blueprint, giving us a visual understanding of this intricate molecular dance right down at the atomic level. It's amazing stuff.
That's truly incredible detail about their internal signaling. So we know the 5 types, we know how they signal inside the cell using these G proteins. But what about their actual physical structure? You said cloning revealed 5 genes, but are the resulting proteins all completely different, or are there similarities that make it hard to target them specifically with drugs? It still seems like if they're too similar, it would be a huge challenge to make a drug that only hits one specific type.
You've hit on a crucial challenge in drug development, and it really speaks to the sophistication needed in modern pharmacology. Over the past decade, we've gotten high-resolution X-ray structures reported for all 5 muscarinic receptors. And what they reveal is that the structures are, in fact, remarkably similar, especially at their main binding pocket.
Ah, okay, so that's the problem.
That's the problem. The classical or orthosteric binding site, this is the primary spot where natural agonists like HE and many traditional antagonists bind, is highly conserved across all 5 receptor subtypes. Imagine it like a deep cleft, sort of buried within the cell membrane, formed by a very similar arrangement of amino acid chains across the receptor's 7 transmembrane helices, or TM helices. A key feature they share with other receptors for what we call biogenic amine ligands, like dopamine or serotonin receptors, is a specific charge interaction. This happens between the positively charged nitrogen atom of the ligands and a conserved aspartic acid residue on TM3 of the receptor. A unique feature specific to muscarinic receptors, though, is the presence of hydrogen bond interactions between the ligand and a specific asparagine residue on TM6. Interestingly, when an agonist binds, the ligand binding pocket actually contracts considerably. This reflects the relatively small size of muscarinic agonists compared to antagonists, which are typically larger molecules. But here's the kicker, the big challenge we keep coming back to. Because the amino acid residues lining this orthosteric binding site are so highly conserved among all 5 muscarinic receptors, developing orthosteric muscarinic ligands drugs targeting this main site with a high degree of receptor subtype selectivity has proven very, very difficult. This is precisely why a drug designed to hit, say, M1 might inadvertently also affect M3, leading to those widespread side effects when you only want it to affect one specific system.
So it's really hard to make a drug that only hits, say, M1 and not M3, because they all look so similar at that main binding site. That sounds like you're fighting against nature's design, like you said. How do researchers overcome this problem? Is there a workaround? Or are we stuck with these broad effects?
That's a brilliant question, and it brings us to one of the most exciting and innovative areas in receptor pharmacology right now: allosteric binding sites.
Allosteric, meaning other shape.
Exactly. Various lines of evidence suggest that muscarinic receptors possess one or more topographically distinct allosteric binding sites. These are essentially secondary binding spots formed by amino acid side chains located elsewhere on the receptor, maybe within the extracellular loops or the outer segments of different transmembrane helices. Crucially, these allosteric regions show a considerable degree of sequence variation among the M1/M5 receptors.
Ah, so they are different.
That sequence variation is the key. It means considerable effort has been directed at developing what are called allosteric modulators that show high selectivity for distinct muscarinic receptor subtypes. Now, these agents exert their pharmacological actions not by directly mimicking or blocking ACI at the primary site, but by subtly altering the shape of the receptor when they bind to their allosteric site. This shape change then modifies the affinity or the efficacy of the natural orthosteric ligand ACI when it binds to the main site. Think of it like a dimmer switch or a volume knob rather than a simple on-off switch.
Okay, that makes sense. Modulating the effect.
Right. Positive allosteric modulators, or PAMs, enhance the orthosteric activity, essentially making AISH more potent or effective, while negative allosteric modulators, or NEMs, inhibit it. Some allosteric agents can even directly activate muscarinic receptors themselves and are then termed allosteric agonists, though these designations can depend a bit on the specific context and the assay system used. The recent progress in identifying subtype selective muscarinic allosteric agents is a really exciting development. It may truly lead to new therapeutic agents with increased efficacy and, importantly, significantly reduced side effects because they can be much more precise. There's currently a lot of research focusing on their potential for treating several severe central nervous system disorders like Alzheimer's disease and schizophrenia, where precise targeting is absolutely paramount.
That sounds incredibly promising.
It really is. We even have an X-ray structure now that revealed the molecular details of how a PAM binds to a muscarinic receptor. Its binding pocket is located just above the main orthosteric binding crevice. And this structure also clearly illustrates that the bound PAM physically interferes with the dissociation, or the unbinding, of the orthosteric agonist from the receptor. That explains precisely why the PAM enhances the actions of the orthosteric ligand. It essentially holds it in place longer, boosting its effect.
Wow.
And there's another strategy, even more cutting edge, for achieving receptor subtype selectivity: the development of hybrid bitopic orthosterical allosteric ligands.
Bitopic, meaning two places.
Exactly. These sophisticated compounds are designed to interact with both the orthosteric binding cavity and an allosteric site simultaneously. By targeting both sites, bitopic ligands can achieve both high affinity for the receptor and remarkable receptor subtype selectivity. This is truly a potential game changer for precise drug design. It allows us to overcome that conservation challenge of the main orthosteric site by exploiting the variability of the allosteric sites. Very clever stuff.
That's a truly brilliant and ingenious approach, especially given how many subtypes there are and how similar they are at that main site. It makes perfect sense you'd need a different strategy. So now that we have these 5 subtypes identified and we understand the challenge of specificity and these new approaches, how are they actually distributed throughout the body? And what challenges still remain in understanding their specific physiological roles?
Well, the 5 muscarinic receptor subtypes are indeed widely distributed, both in the central nervous system and in peripheral tissues. It's important to note, and this adds another layer of complexity, that most cells actually express at least 2 subtypes, sometimes more.
Oh, okay. So it's not just one type per cell, usually.
Rarely. This makes it even more complicated to dissect their individual roles and understand precisely what each one is doing in a given tissue or response. Historically, identifying the precise role of a specific subtype and mediating a particular muscarinic response to AC has been difficult, precisely because of that long-standing lack of truly subtype-specific agonists and antagonists that we just discussed. If you don't have a precise tool, it's hard to isolate the effect, right?
Makes sense.
However, recent studies using advanced techniques like M1/M5 receptor knockout mice, where scientists genetically remove a specific receptor subtype and then observe the physiological consequences, have provided novel and invaluable information about the physiological roles of the individual subtypes. These knockout studies have shown us that typically multiple receptor subtypes are involved in mediating specific muscarinic responses. For example, abolishing something like cholinergic bronchoconstriction or salivation or pupillary constriction or even bladder contraction generally requires the deletion of more than one receptor subtype.
Interesting. So it's cooperative.
Often, yes. This means that a single drug targeting just one subtype might not fully achieve the desired physiological effect. which again emphasizes the inherent complexity we're dealing with and why those bitopic ligands and allosteric modulators are so promising for future therapies that might need to target multiple subtypes or modulate them subtly. It's definitely a symphony of subtle interactions.
Now that we understand the receptors themselves, their subtypes, the signaling, the challenges of targeting them, let's bring it to life. What happens when ATA actually binds to them throughout the body? This is the so what, right? How these drugs actually exert their therapeutic effects. It's about connecting the molecular details to the physiological outcomes.
Precisely. Understanding these widespread physiological effects of acetylcholine is the essential background. It's the foundation for understanding the rationale and mechanisms behind the therapeutic uses of both muscarinic receptor agonists, which mimic ATA, and antagonists, which block its actions. Without this foundational knowledge, the clinical applications wouldn't make much sense. It's really the map to the territory we're exploring.
Okay, let's start our tour with the heart and blood vessels, the cardiovascular system. What does AC do there?
Okay, AC has 4 primary effects on the cardiovascular system. First, vasodilation, which means widening of blood vessels. Second, a decrease in heart rate, which pharmacologists call a negative chronotropic effect. Third, a decrease in conduction velocity in the atrioventricular or AV node. That slows the electrical signal traveling from your atria down to your ventricles. That's a negative dromotropic effect. And fourth, a decrease in the force of cardiac contraction, which is a negative inotropic effect, though this specific effect is generally less significant in the ventricles compared to the atria.
Okay, 4 key effects.
Right. And it's important to remember that some of these direct effects can sometimes be subtle or even obscured by your body's natural compensatory mechanisms, like baroreceptor reflexes, which try to maintain balance when blood pressure or heart rate changes. But the cardiac actions of FE are clinically very important. Why? Because the effects of many other drugs you might be familiar with, like cardiac glycosides such as digoxin or some antiarrhythmic agents, are at least partly due to changes they induce in parasympathetic or vagal stimulation of the heart. Also, even during surgical interventions, particularly in the abdomen or chest, stimulating certain nerves can reflexly increase vagal stimulation of the heart, which can significantly impact a patient's heart rate during the procedure. So surgeons and anesthesiologists need to be very aware of this.
That's a comprehensive overview. But how does that vasodilation actually happen at the molecular level? What's the precise mechanism that leads to blood vessels widening when FE hits them?
Right, so when you inject a relatively small dose of HE intravenously, it typically produces a transient, meaning temporary, fall in blood pressure. This drop is due to generalized vasodilation happening throughout the body, and this drop in blood pressure is usually accompanied by a reflex tachycardia, where your heart speeds up as your body tries to compensate for that sudden fall in pressure. It's trying to maintain perfusion.
Okay.
Now, the generalized vasodilation produced by administered HCOs is primarily mediated by M3 muscarinic receptors located on those vascular endothelial cells, the delicate inner lining of your blood vessels.
M3 again?
M3 again. When these M3 receptors are occupied by HCO, it triggers that GQ-PLC-IP3 pathway we talked about earlier. This cascade then leads to a calcium calmodulin-dependent activation of an enzyme called endothelial NO synthase, or ENO. This ENOS enzyme then produces nitric oxide, or NO, which you might also know as endothelium-derived relaxing factor.
Oh, nitric oxide. I've heard of that.
Exactly. NO then diffuses from the endothelial cells to the adjacent vascular smooth muscle cells. There, it stimulates another enzyme called soluble guanylate cyclase. This, in turn, promotes relaxation of the smooth muscle via a cyclic GMP-dependent mechanism. This entire pathway is absolutely crucial for blood pressure regulation. Even things like baroreceptor reflexes or direct vagus nerve stimulation can elicit coronary vasodilation mediated by NO and this NO production pathway. However, and here's a crucial and quite fascinating detail for clinicians, if the endothelium is damaged, which happens in various diseases like atherosclerosis,
Right.
NO doesn't act primarily on the endothelium anymore. Instead, it acts predominantly on M3 receptors located directly on the underlying vascular smooth muscle cells. And guess what happens then? Vasoconstriction instead of dilation. This capacity for ASO to both relax and constrict vessels, depending entirely on the health of the endothelium, highlights the complex interplay of receptors and the condition of the tissue. It's a really important physiological switch. Beyond that, NO generation in the heart itself has many other subtle effects and might even contribute to what's called vagal dominance, where the parasympathetic system exerts more control over the heart.
Fascinating. So it can actually cause constriction if the vessel lining is damaged. That's a critical nuance for clinicians to understand. Okay, what about the direct effects on the heart muscle itself, beyond just the blood vessels?
You've picked up on a key point. ASO does have direct effects on cardiac function, particularly at doses that are higher than those needed for that NO-mediated vasodilation we just discussed. These direct cardiac effects are primarily mediated by M2 muscarinic receptors,
M2 this time.
M2 in the heart muscle primarily. These direct effects include an increase in the AC-activated potassium current, known as IKX. This is due to activation of specific potassium channels that hyperpolarize the cell, essentially making it harder to fire an action potential. Also, a decrease in the L-type calcium current, IKL, and consequently L-type calcium channel activity. This occurs because AX via M2 receptors diminishes cyclic AMP generation inside the cell. And thirdly, a decrease in the cardiac pacemaker current, known as IF, which is caused by reduced activity of certain channels called HCM channels. Now, the collective actions of ACER on these M2 receptors lead to a Guy-mediated decrease in cyclic AMP. This is very significant because it directly opposes and counteracts the bilirubin adrenergic mediated increase in cyclic AMP, which is the core mechanism of your fight or flight sympathetic response trying to speed up the heart.
So it's like putting the brakes on the accelerator.
Exactly. It's a crucial balance system, a biological braking mechanism. Additionally, ACEs released from those parasympathetic nerve terminals also acts on presynaptic M2 and M3 receptors located on adjacent sympathetic nerve terminals. This action serves to inhibit the release of norepinephrine from those sympathetic nerves, further modulating or dampening the sympathetic response indirectly. And there are even presynaptic M2 receptors that inhibit ACIC release from the parasympathetic nerve terminals themselves right there in the human heart. This illustrates even more complex feedback loops in autoregulation. It's incredibly intricate.
That's a lot of intricate signaling, layer upon layer. Let's try to break down its effects on different parts of the heart to make it even clearer for our listeners. Maybe walk through each major area.
Certainly. Let's start with the sinoatrial SA node. This is the natural pacemaker that initiates each normal cardiac impulse. Here, AC slows the heart rate primarily by decreasing the rate of spontaneous depolarization. This essentially delays the attainment of the threshold potential required for an action potential and the subsequent events in the cardiac cycle, thereby slowing your heart down. Now, until recently, it was widely accepted that these effects on heart rate resulted mainly from regulating that cardiac pacemaker current, IF. But recent findings from genetic deletion studies and pharmacological inhibition have generated an alternative, quite intriguing theory. It involves an intracellular calcium clock mechanism that might also mediate ACT's effects on heart rate. So the picture is still evolving, which is often the case in cutting-edge science. It might be more complex than we first thought.
Okay, ACE node slows down. What about the atria, the upper chambers?
In the atria, HEC causes hyperpolarization and a decreased action potential duration, primarily by increasing that IKA potassium current we mentioned. It also inhibits cyclic AMP formation and norepinephrine release, as we discussed, both of which contribute to decreasing the force of atrial contraction or atrial contractility.
And the AV node, that crucial junction between atria and ventricles.
In the AV node, ASHE significantly slows conduction velocity and increases the refractory period, mainly by inhibiting that L-type calcium current, AAL. This decrement in AV conduction is quite potent and is actually responsible for the complete heart block that can be observed when large quantities of cholinergic agonists are administered systemically.
Wow, it can actually block the signal completely.
In high doses, yes. For you, the listener, this is important because if your parasympathetic tone to the heart is increased, maybe by certain medications like digoxin, the prolonged refractory period of the AV node caused by this effect can reduce the frequency with which aberrant atrial impulses are transmitted down to the ventricles. This helps decrease your ventricular rate during conditions like atrial flutter or fibrillation. It's a key therapeutic mechanism for managing those fast atrial arrhythmias.
Yeah, makes sense. Okay, now what about the ventricles and his Purkinje system, the main pumping chambers, and their conduction network?
Right. The ventricles and his Purkinje system receive only sparse cholinergic or parasympathetic vagal innervation compared to the nodes and atria. So the direct effects of HE here are generally smaller than what we see higher up in the heart. The modest negative endropic effect, the decreased force of contraction in the ventricle, is most apparent when there is concomitant adrenergic stimulation or significant underlying sympathetic tone, because the HE tends to counteract that sympathetic drive. It can also suppress the automaticity, the tendency to self-fire of Purkinje fibers, and increase the threshold for ventricular fibrillation, offering some potentially protective effects against dangerous ventricular arrhythmias, which is definitely a beneficial outcome.
Okay, moving beyond the heart now, what about breathing? How does HA affect the respiratory tract, specifically your airways and lungs?
The parasympathetic nervous system plays a major, often underappreciated, role in regulating what we call bronchomotor tone. That's essentially the tightness or relaxation of your airways. A diverse set of stimuli, things like irritants, allergens, even cold air, can cause reflexes that increase parasympathetic activity, leading to bronchoconstriction or the narrowing of your airways. So, the effects of ARC on your respiratory system therefore include bronchoconstriction, increased tracheobronchial secretion, which means more mucus production, and also stimulation of the chemoreceptors in your carotid and aortic bodies. Those are sensors that detect changes in blood gases like oxygen and CO2. These effects are primarily mediated by M3 muscarinic receptors located on bronchial and tracheal smooth muscle. They become most obvious and pronounced in cases of severe toxicity from cholinesterase inhibition, such as from certain types of pesticides or even nerve agents, where ADC levels build up to dangerously high concentrations, causing severe breathing difficulty.
And what about the urinary tract? How does ADC influence our ability to urinate?
In the urinary tract, parasympathetic sacral innervation causes detrusor muscle contraction. That's the main muscle of the bladder wall, which increases voiding pressure. It also stimulates urethral peristalsis, the wave-like contractions that move urine down from the kidneys. Both are processes crucial for urination. However, it's often difficult to observe these specific responses clearly when HHS is administered therapeutically as a drug. This is mainly because of poor blood perfusion to visceral organs and its very rapid hydrolysis by plasma enzymes, both of which limit how much of the systemically administered HAOH actually reaches the target muscarinic receptors in the bladder and ureters. Nevertheless, when it does act, muscarinic stimulation of bladder contraction is primarily mediated by M3 receptors expressed by those detrusor smooth muscle cells. M2 receptors on the smooth muscle also seem to make a small but notable contribution to this response. They do this partly by reversing the relaxation that beta receptors, part of the sympathetic system, and cyclic AMP would normally cause, and also via other indirect effects, all contributing to the overall contraction that aids urination.
The GI tract is another major area of parasympathetic control. What are the key effects of HE there for digestion and gut motility?
Right. While vagal input to the gastrointestinal, or GI, tract definitely increases tone, the amplitude of contractions, and the secretory activity of the stomach and intestine. You'll find that such responses are inconsistently seen with administered HE for the very same reasons as the urinary tract.
Poor access, rapid breakdown.
Exactly. Poor access due to rapid breakdown and limited perfusion of the visceral organs. However, when it does act effectively, just like in the urinary tract, M3 receptors appear to be primarily responsible for mediating cholinergic control of GI motility, but M2 receptors also contribute to this complex regulation. So again, M3 seems to be the main player for contraction and motility, but M2 also has a supporting role in the gut.
What about secretions from other glands throughout the body, like tears or sweat or saliva?
Good question. In addition to its stimulatory effects on tracheobronchial and GI secretions, AC stimulates secretion from many other glands that receive either parasympathetic or, interestingly, sympathetic cholinergic innervation. This includes your lacrimal glands, which produce tears, nasopharyngeal glands involved in nasal secretions, salivary glands producing saliva, and sweat glands responsible for perspiration.
Wait, sympathetic cholinergic? I thought sympathetic was fight or flight.
Mostly, yes, but sweat glands are a key exception. They are innervated by sympathetic nerves, but those nerves release AC onto muscarinic receptors, not norepinephrine like most sympathetic nerves. It's a fascinating quirk of the autonomic nervous system.
Huh, okay. So AC stimulates all these glands.
Yes, and all of these secretory effects are primarily mediated by M3 muscarinic receptors. However, it's worth noting that M1 receptors also seem to contribute specifically to the cholinergic stimulation of salivary secretion, showing again that sometimes multiple subtypes can play a role in a single physiological function.
And finally, our eyes. What exactly happens when AC acts on them?
When ECA is instilled directly into the eye, maybe as eye drops during surgery, it produces miosis. That's pupillary constriction, where your pupil gets smaller. This happens because it contracts the pupillary sphincter muscle in the iris. It also causes accommodation for near vision by contracting the ciliary muscle, which changes the shape of your lens, allowing your eye to focus on close objects. Both of these important ocular effects are primarily mediated by M3 muscarinic receptors, though again, other subtypes might contribute subtly to the overall complex cholinergic effects in the eye.
You mentioned earlier that muscarinic receptors are widely distributed in the CNS. What are their broad effects there, given that systemic IGA itself has such limited penetration into the brain?
That's right, all 5 muscarinic receptor subtypes, M1 through M5, are expressed in the brain. Recent studies strongly suggest that muscarinic receptor-regulated pathways play an incredibly important role in critical functions like cognitive function, memory, learning, motor control, appetite regulation, nociception, which is pain perception, and various other complex processes. So even if the natural neurotransmitter doesn't easily get there from the bloodstream, the system itself, the receptors within the brain, are profoundly important. While systemically administered ASHIT itself has limited CNS penetration, muscarinic agonists that can cross the blood-brain barrier evoke a characteristic cortical arousal or activation response. This response is quite similar to what you'd see if you injected cholinesterase inhibitors, which boost natural ASHET levels within the brain by preventing its breakdown, or if you electrically stimulated the brainstem reticular formation, which is a key area involved in consciousness and wakefulness. This clearly indicates their profound impact on brain activity and alertness, even though direct application of ASHET from the outside is problematic.
So, given that natural ASHI isn't a good drug on its own because of its rapid breakdown and diffuse action, how do scientists create drugs that actually mimic its effects effectively? What are muscarinic receptor agonists, pharmacologically speaking?
Okay. Muscarinic cholinergic receptor agonists are drugs specifically designed to mimic the muscarinic receptor-mediated effects of HE. They generally fall into 2 main groups, based on their chemical structure and origin. The first group is choline esters. This includes Akish itself, which, as we discussed, isn't used systemically, but also several synthetic esters that have been carefully designed to be more stable and therefore longer acting in the body. The second group is naturally occurring cholinomimetic alkaloids. These specifically include compounds like pilocarpine, muscarine, and orecholine, along with their synthetic cousins or congeners. It's important to note that of several hundred synthetic choline derivatives that have been investigated over the years, only 3 methacholine, carbachol, and bethanicol are currently in widespread clinical use.
Only 3 out of hundreds.
Yep. The others either lacked sufficient specificity or stability, or maybe had unacceptable side effect profiles, really emphasizing the challenges of drug development. Finding the right balance is tough.
Let's talk about some of these specific synthetic agonists then. How does a drug like methacholine or maybe bethanicol offer an advantage over natural HE? What makes them usable?
Great question. The key advantage comes from specific chemical modifications that improve stability and sometimes selectivity. Take methacholine, for example. It's acetylmethylcholine, a synthetic choline ester. It differs from HE chiefly in its greater duration of action and its selectivity. Its action is more prolonged because a small chemical addition, a methyl group, increases its resistance to hydrolysis by those cholinesterases. It just doesn't get broken down as quickly as natural HGO.
Okay, makes it last longer.
Exactly. And its selectivity is seen in a predominance of muscarinic actions, most clearly in the cardiovascular system, while its nicotinic actions are quite minor. This makes it a cleaner muscarinic mimic for certain therapeutic uses, like diagnostic testing. Now, carbachol and its close relative bethanicol are a bit different. They are unsubstituted carbamoyl esters. Chemically, this means they are almost completely resistant to hydrolysis by cholinesterases.
Even more stable.
Much more stable. This chemical property is crucial because it means their half-lives are sufficiently long for them to be distributed effectively, even to areas of low blood flow, allowing them to reach their targets more reliably throughout the body. Carbachol specifically retains substantial nicotinic activity, particularly on autonomic ganglia, which is an important distinction to remember. It can cause different side effects compared to a purely muscarinic agent because of that nicotinic action. Bethanicol, on the other hand, has mainly muscarinic actions with very prominent and clinically useful effects on the motility of the GI tract and the urinary bladder. This makes it a nicely targeted tool for those specific systems.
And what about the natural alkaloids, like muscarine and pilocarpine? What's their clinical story? Are they used often?
The major natural alkaloid muscarinic agonists, muscarine, pilocarpine, and arginine, they have the same principal sites of action as the choline esters we just discussed. Muscarine acts almost exclusively at muscarinic receptors, but as we said, it's primarily of toxicological significance, often found in those poisonous mushrooms, not really used therapeutically. Pilocarpine has a dominant muscarinic action, but interestingly, it's a partial rather than a full agonist. This means it doesn't elicit a maximal response even at high concentrations. A unique feature is that the sweat glands are particularly sensitive to pilocarpine, making it useful for treating conditions involving dry mouth or needing sweat induction.
Partial agonist. That's interesting.
It is, and arecaline acts on both muscarinic and nicotinic receptors. It's the main alkaloid found in areca, or betel nuts, which are consumed as a euphoretic, sort of mildly stimulating mixture in some cultures, but not really for medicinal purposes in Western medicine. So while these naturally occurring alkaloids are important pharmacological tools and certainly have toxicological significance, their current clinical use is largely restricted to pilocarpine. Pilocarpine is employed as a silagogue, that's a drug that induces salivation, and also as a miotic agent, meaning it causes pupillary constriction, typically in eye drops for glaucoma.
That makes sense. Okay, given their varied chemical structures and origins, synthetic esters, natural alkaloids, how are these compounds absorbed and distributed in the body? What's their ADME profile like, and how does that impact their clinical use?
Right. Their absorption, distribution, metabolism, and excretion, the ADME profile, can be largely predicted from their structures. This is a foundational concept in pharmacology. Structure often dictates function and behavior in the body. Muscarine and the synthetic choline esters, like methacholine, carbachol, and bethanechol, are quaternary amines.
Quaternary meaning they have a fixed positive charge.
Exactly. As such, they are poorly absorbed following oral administration and have a limited ability to cross the blood-brain barrier. This means they generally won't affect the CNS significantly, which can be a good thing if you're trying to avoid central side effects like confusion or dizziness. Even though some of them resist hydrolysis better than us, they are still relatively short-acting agents overall, partly due to rapid elimination by the kidneys. In contrast, pilocarpine and arecaline are tertiary amines.
Tertiary meaning they can exist in charged or uncharged forms.
Correct. This chemical distinction is important because it means they are readily absorbed from the GI tract and, crucially, they can cross the blood-brain barrier. This allows them to affect the central nervous system, which can be both a benefit, maybe for treating cognitive issues, or a risk leading to central side effects. Now, while muscarine is a quaternary amine and poorly absorbed, it can still be toxic when ingested in large amounts, like from mushrooms, and surprisingly, can even have some CNS effects, demonstrating that poorly absorbed isn't not absorbed at all in all cases, especially with high doses. The natural alkaloids are primarily eliminated by the kidneys. And interestingly, excretion of the tertiary amines like pilocarpine can actually be accelerated by acidifying the urine. This helps to trap the cationic ionized form in the urine, preventing its reabsorption back into the bloodstream and speeding its removal from the body. A useful clinical trick sometimes.
So for you, the listener, what are these muscarinic agonists actually used for in medicine today? What specific conditions do they treat in the real world?
Okay, clinically, muscarinic agonists are currently used primarily in the treatment of urinary bladder disorders, often involving issues with bladder emptying or retention. They're also widely used for xerostomia, the medical term for dry mouth. They have a specific use in the diagnosis of bronchial hyperreactivity through what's called a bronchoprovocation test using methacholine to see how reactive a patient's airways are, helping diagnose conditions like asthma. And as we mentioned, they're used extensively in ophthalmology as miotic agents to constrict pupils and for the treatment of glaucoma by improving the outflow of fluid from the eye, which lowers pressure. There's also growing interest, particularly in the research community, in exploring the potential of M1 selective agonists to treat cognitive impairments, especially those associated with serious neurological conditions like Alzheimer's disease. Other receptor subtypes, including M2 and M5, also appear to be involved in regulating cognitive function, at least in animal models, suggesting a complex interplay in brain function that we're still unraveling and hoping to target therapeutically.
Can you give us a few specific illustrative examples of these agents and their particular uses? Maybe highlight what makes them unique or important in clinical practice.
Certainly. Let's take acetylcholine itself first. While it's rarely given systemically for all the reasons we discussed, it is used topically in ophthalmology, directly in the eye, to induce rapid miosis or pupil constriction during certain eye surgeries, like cataract surgery. It's typically instilled as a 1% solution right into the eye. Short-acting, localized effect.
Okay, so direct application works.
Exactly. Then there's methacholine, This is administered by inhalation specifically for diagnosing bronchial airway hyperreactivity in patients who don't have clinically obvious asthma. It comes as a powder that's diluted and given via a nebulizer. Now, while it can cause some bronchoconstriction and increase secretions in almost everyone, asthmatic patients respond with intense bronchoconstriction and a significant reduction in their vital capacity. It's a challenge test.
So it reveals the underlying problem.
Precisely. It's a diagnostic tool, not a treatment. And it needs to be done carefully. There are contraindications like severe airflow limitation or recent heart attack, and emergency equipment must be available because you're intentionally provoking a reaction. Next, bethanechol. This drug primarily affects the urinary and GI tracts. In the urinary tract, it's particularly useful for treating urinary retention and inadequate bladder emptying, especially when there's no physical obstruction, think post-operative urinary retention, or in diabetic patients with nerve damage or certain types of chronic bladder weakness. It can effectively help patients avoid the need for catheterization. For chronic use, it's typically taken orally, maybe 10 to 50 milligrams 3 or 4 times daily, usually on an empty stomach to minimize potential nausea and vomiting.
And its GI effects.
In the GI tract, bethanechol stimulates peristalsis, increases motility, and increases the resting pressure of the lower esophageal sphincter. It was formerly used more often for things like postoperative abdominal distension or gastroparesis, but now, frankly, more efficacious therapies are usually available for those conditions. Carbachol is another one used topically in ophthalmology, similar to acetylcholine, for treating glaucoma and inducing meiosis during surgery, typically as a 0.01% to 3% solution. Pilocarpine hydrochloride is a real workhorse for xerostomia or dry mouth, especially after head and neck radiation treatments, or when it's associated with Sjogren's syndrome, that autoimmune disorder affecting glands. If the salivary gland tissue still has some residual function, treatment with pilocarpine can significantly enhance salivary secretion, easing swallowing and subjectively improving how hydrated the mouth feels. Side effects are typical of cholinergic stimulation, with sweating being the most common complaint. The usual dose is 5 to 10 milligrams 3 times daily. It's also used topically in ophthalmology for glaucoma and as a miotic agent. And finally, cefamolene. This is another muscarinic agonist used for dry mouth, noted for having a long-lasting saligogic action on both lacrimal and salivary glands. It may have fewer overall side effects and perhaps better patient compliance compared to pilocarpine, possibly because it preferentially activates M1 and M3 receptors. The usual dose is 30 milligrams 3 times daily. This highlights that ongoing quest for more targeted drugs even within the agonist class.
With all these effects and the potential for widespread action if absorbed systemically, what are the potential downsides? What are the situations where these agonist drugs should be absolutely avoided?
Right. Most contraindications and adverse effects of muscarinic agonists are predictable consequences of excessive muscarinic receptor stimulation. Essentially, your rest and digest system going into overdrive inappropriately. So it's essential for clinicians and patients to be aware. Important contraindications include conditions like asthma or chronic obstructive pulmonary disease, COPD, because they can worsen bronchoconstriction. Any form of urinary or GI tract obstruction, as stimulating contraction against a blockage can be dangerous. Acid peptic disease due to increased acid secretion, cardiovascular disease accompanied by bradycardia, slow heart rate, or hypotension, low blood pressure, where they can dangerously lower heart rate or blood pressure further. And interestingly, hyperthyroidism, as muscarinic agonists, may actually precipitate atrial fibrillation in these individuals.
Wow.
Common adverse effects you might experience include excessive sweating, diarrhea, abdominal cramps, nausea, vomiting, and other GI side effects, maybe a sensation of tightness in the urinary bladder, visual disturbances like blurred vision due to accommodation issues, and hypotension, which, if severe, can significantly reduce coronary blood flow, especially if it's already compromised. It's important to note, though, that these contraindications and adverse effects are generally of much more limited concern with topical administration, like for ophthalmic use, where systemic absorption is minimal and therefore widespread effects are far less likely.
And what about toxicology? What happens if someone gets way too much of these substances, perhaps from an accidental ingestion of a poisonous mushroom containing muscarine?
Yeah. Poisoning from ingesting plants containing pilocarpine, muscarine, or arecoline is characterized chiefly by a pronounced exaggeration of their various parasympathomimetic effects. Think of it as your rest and digest system going into severe, uncontrolled overdrive. You get the classic signs: excessive salivation, lacrimation, tears, urination, defecation, GI upset like cramping and vomiting, severe bronchoconstriction making breathing difficult, bradycardia, hypotension. It can be life-threatening. Treatment typically involves the parenteral administration, usually of atropine, which is a muscarinic antagonist. It needs to be given in doses sufficient to cross the blood-brain barrier to counteract both peripheral and central effects. This is done along with supportive measures, of course, to maintain the respiratory and cardiovascular systems and to counteract pulmonary edema or fluid in the lungs, which can be a major, often fatal complication.
So if agonists mimic HED and push the rest and digest system into action, sometimes excessively, what do antagonists do? They must be crucial for balancing the system when it's overactive or when we want to block those effects therapeutically.
Exactly. Muscarinic receptor antagonists do the precise opposite. They prevent the effects of AC by competitively blocking its binding to muscarinic receptors. They essentially sit on the receptor but don't activate it, preventing AC from getting there. They do this on effector cells at parasympathetic junctions and even some sympathetic cholinergic junctions like sweat glands, also in peripheral ganglia, and importantly, in the central nervous system. Generally, muscarinic antagonists cause little blockade of nicotinic receptors, the other type of acetylcholine receptor. However, it's worth noting that the quaternary ammonium antagonists, due to their chemical structure with that fixed charge, usually exhibit a greater degree of nicotinic blocking activity. This makes them more likely to interfere with ganglionic or neuromuscular transmission, which can have its own set of effects and potential side effects.
Okay, so they block the signal. Is it always straightforward? You mentioned paradoxical effects earlier.
Right? It's not always perfectly straightforward. An important subtlety about these antagonists is that while many of their effects can be predicted simply by understanding which muscarinic receptor functions they're blocking, paradoxical responses can occur. For example, remember those presynaptic muscarinic receptors we mentioned on parasympathetic nerve terminals? They normally inhibit further AC release.
Right, the feedback loop.
Exactly. So because blockades of these presynaptic receptors generally augments neurotransmitter release, it blocks the inhibitor, so you get more AC release initially. The presynaptic effects of muscarinic antagonists may actually counteract their intended postsynaptic receptor blockade, at least transiently. It's like trying to turn off a faucet, but your action briefly makes the water flow a tiny bit faster before it finally flows down. Blockade of the modulatory muscarinic receptors in peripheral ganglia represents another mechanism for these sometimes paradoxical responses, highlighting again the complex feedback loops in the nervous system.
That's fascinating and complex. So, what are the main types of these antagonists that we see in use, and what distinguishes them? Are they natural or synthetic?
The muscarinic receptor antagonists broadly include three main categories. First, the naturally occurring alkaloids like atropine and scopolamine, which famously come from plants in the nightshade family, like deadly nightshade or Jimson weed, which contain belladonna alkaloids. Second, semi-synthetic derivatives of these alkaloids. These are chemically modified versions of atropine or scopolamine, often designed to improve their properties, like how they're handled by the body or how long they last. And third, synthetic derivatives. Some of these are specifically designed to even show a limited degree of selectivity for certain muscarinic receptor subtypes, which is a major advancement, helping us avoid some of those widespread side effects we see with the non-selective ones.
Can you give some examples?
Sure. Noteworthy agents in the last two categories include homatropine and tropicamide, which have shorter durations of action compared to atropine, making them useful in specific settings like eye exams. Then there are the quaternary amines like methscopolamine, ipratropium, tiotropium, aclidinium, and meclidinium. These are specifically designed not to cross the blood-brain barrier or readily cross other cell membranes, which is crucial for limiting their systemic effects primarily to the periphery, like the lungs or gut.
That targeted delivery seems key.
It is. And among the synthetic derivatives possessing some degree of receptor subtype selectivity, we have drugs like pirenzepine, which is an M1 receptor-preferring antagonist, and darafenacin and solifenacin, two M3 receptor-preferring agents used mainly for overactive bladder. This subtype selectivity, even if limited, is a big deal because it allows for more targeted therapies with potentially fewer off-target side effects, a major goal in modern pharmacology.
You mentioned atropine as a prototype for these antagonists.
Yeah.
How sensitive are different parts of the body to its effects? Is it a one-dose-fits-all kind of drug? Or do different organs respond differently even to the same dose?
This is a really crucial consideration for therapeutic use, and it's one of those surprising facts that's vital for understanding clinical practice. Physiological functions in different organs vary significantly in their sensitivity to muscarinic receptor blockade by drugs like atropine. It is absolutely not a one-dose-fits-all drug.
Okay, so there's a hierarchy.
Exactly. There's a clear hierarchy of effects based on dose. Consider this. Small doses of atropine, maybe as little as 0.5 milligrams, will first depress salivary and bronchial secretion and sweating. So, dry mouth, less mucus, and less sweat are the very first signs you typically notice. With slightly larger doses, maybe around 1 milligram, your pupil will dilate, mydriasis. Accommodation for near vision will be inhibited, cycloplegia, meaning you can't focus on close objects. And vagal effects on the heart are blocked, causing your heart rate to increase, tachycardia. Still larger doses, maybe around 2 milligrams or more, are required to significantly antagonize parasympathetic control of the urinary bladder and the GI tract, thereby inhibiting urination and decreasing intestinal tone and motility. And the highest doses, often 5 milligrams or more, are needed to fully inhibit gastric motility and particularly gastric acid secretion.
That's a really clear progression.
It is, and the implication for you, the listener, and especially for clinicians, is that doses of atropine and most related non-selective muscarinic antagonists that are high enough to effectively depress gastric secretion will almost invariably also affect salivary secretion, ocular accommodation, urination, and GI motility quite profoundly. This widespread effect profile severely limits their utility when a very specific action is desired without causing bothersome side effects elsewhere. Now, this hierarchy of sensitivities is not because atropine itself is selective for different muscarinic receptor subtypes. It actually lacks that selectivity and binds pretty equally to all muscarinic receptors.
So why the different sensitivities then?
It's likely due to a combination of factors. Things like the intrinsic degree to which various organs are regulated by baseline parasympathetic tone, the extent of receptor reserve, meaning how many spare receptors are present in different tissues, the complex involvement of intramural neurons and reflexes within the organs themselves, and the presence of other counter-regulatory mechanisms. Most clinically available muscarinic antagonists, unfortunately, lack significant receptor subtype selectivity, and their actions often differ little from those of atropine, reinforcing this challenge of broad side effects with these older, non-selective agents.
That's a great practical insight into why side effects can be so widespread and dose-dependent with these general antagonists. Okay, let's delve into the specific pharmacological effects now, using atropine as our guide again. How do they affect the heart specifically? You mentioned tachycardia.
Right. The main effect of atropine on the heart is indeed to alter its rate. While the dominant expected response at therapeutic doses is tachycardia and increased heart rate, there's often that curious transient bradycardia or slowing observed with average clinical doses, maybe around 0.4 to 0.6 milligrams, especially if given slowly.
The paradoxical effect again.
Exactly. This initial slowing is usually modest and typically absent if the drug is injected rapidly intravenously. As we touched on, this unexpected initial slowing has been attributed to the block of those presynaptic M1 muscarinic receptors located on parasympathetic nerve terminals in the SA node. Since these M1 receptors normally inhibit unsheet release, blocking them briefly increases unsheet release, causing the transient slowing. However, larger doses of atropine cause progressive and more pronounced tachycardia. This happens by blocking the M2 receptors directly on the SA nodal pacemaker cells, thereby directly antagonizing the normal parasympathetic or vagal tone to the heart. This is the effect most people expect from atropine. Your resting heart rate can increase significantly, maybe by about 35 to 40 beats per minute in healthy young men given 2 milligrams of atropine intramuscularly. Interestingly, though, the maximal heart rate, like what you'd achieve during intense exercise, is not altered by atropine because that maximum rate is primarily driven by the sympathetic system. The influence of atropine is most noticeable in healthy young adults who naturally have considerable resting vagal tone. In infants, the elderly, and patients with heart failure, even large doses of atropine may fail to accelerate the heart significantly, simply because their baseline vagal tone is lower or their heart is less responsive.
Okay, and besides rate?
Atropine can also abolish many types of reflex vagal cardiac slowing or even a systole cardiac standstill, such as those that can occur from inhaling irritant vapors or during certain surgical procedures involving visceral manipulation. Atropine also prevents or abruptly abolishes bradycardia or asystole caused by cholinesters, epistylcholinesterase inhibitors, or other parasympathomimetic drugs. By removing that vagal tone, atropine can facilitate AV conduction, speeding up the electrical signal through the AV node. It shortens the functional refractory period of the AV node and can therefore increase the ventricular rate in patients who have atrial fibrillation or flutter by allowing more impulses to pass down from the atria. This can be therapeutically beneficial in certain arrhythmia settings, like managing digoxin toxicity where vagal tone is high.
What about blood pressure and overall circulation? Do these antagonists cause a significant spike in blood pressure, maybe due to the increased heart rate?
Interestingly, atropine alone usually has little direct effect on blood pressure. This is because most blood vessels lack significant cholinergic innervation. The sympathetic nervous system primarily controls vascular tone, remember?
Right. No M receptors on most vessel muscles directly.
Primarily, yes. However, in clinical doses, atropine does completely counteract the peripheral vasodilation and the sharp fall in blood pressure caused by exogenously administered choline esters, like the muscarinic agonists we discussed earlier. It blocks their effect. Now, in toxic doses, and occasionally even in therapeutic doses, atropine can indirectly dilate cutaneous blood vessels, especially those in the blush area, face, neck, upper chest, leading to what's commonly known as atropine flush.
Why does it happen?
It's thought to be a compensatory reaction. By inhibiting sweating, atropine can cause body temperature to rise. Dilating these superficial blood vessels allows for heat radiation, helping to offset that rise in temperature. It's the body trying to cool itself down when it can't sweat effectively.
How do these antagonists impact the respiratory system? We talked about agonists causing bronchoconstriction and mucus. What's the opposite effect with antagonists?
While atropine can cause some degree of bronchodilation and a noticeable decrease in tracheobronchial secretion in normal individuals by blocking the baseline parasympathetic or vagal tone to the lungs, its effects on the respiratory system are most significant and therapeutically relevant in patients with existing respiratory disease like COPD or asthma. Atropine can inhibit bronchoconstriction caused not just by direct vagal stimulation, but also by various inflammatory mediators like histamine or bradykinin, suggesting that these mediators often involve reflex parasympathetic activity as part of their mechanism. This ability to block the indirect bronchoconstrictive effects of these mediators forms the basis for using muscarinic receptor antagonists, often alongside beta-adrenergic receptor agonists, in the treatment of asthma and especially chronic obstructive pulmonary disease, COPD.
And the secretions.
Atropine broadly inhibits the secretions of the nose, mouth, pharynx, and bronchi, and thus effectively dries the mucous membranes of the respiratory tract. This action is especially marked if secretion is excessive to begin with. This property formed the basis for its historical use during anesthesia to prevent irritating inhalational anesthetics from increasing bronchial secretion, though newer anesthetics are generally less irritating now. Muscarinic antagonists are also used today to decrease rhinorrhea, or runny nose, associated with the common cold, or with allergic and non-allergic rhinitis. It's worth noting again that the drying effect of first-generation antihistamines often found in non-prescription cold medications is primarily due to their anti-muscarinic properties, rather than their antihistaminic effects, except in actual allergic conditions.
But you mentioned a downside to drying secretions.
Yes, a potential undesirable side effect, particularly for patients with significant underlying airway disease, is that reducing mucus secretion and also inhibiting mucociliary clearance, the natural mechanism for clearing mucus can unfortunately result in the formation of thick, tenacious mucus plugs, which can actually worsen airway obstruction.
Which leads us back to those inhaled, targeted drugs.
Exactly. This is where the specific respiratory drugs like ipratropium, tiotropium, aclidinium, and meclidinium come in. These are quaternary ammonium compounds, remember, so they are poorly absorbed systemically when inhaled. They are used almost exclusively for their effects on the respiratory tract. Dry mouth is often their only frequently reported side effect because their absorption from the lungs or the GI tract, if swallowed after inhalation, is very inefficient. They don't get into the bloodstream significantly. This is a huge advantage for avoiding those widespread systemic side effects like blurred vision or urinary retention. The bronchodilation from these inhaled agents reflects blockade of the basal parasympathetic tone, supplemented by blockade of reflex cholinergic pathways. A therapeutically important property, especially of ipratropium and tiotropium, is their minimal inhibitory effect on mucociliary clearance compared to atropine. This is why they are preferred for chronic airway disease management, as they minimize the risk of increased accumulation of lower airway secretions and those troublesome mucus plugs, while still providing effective bronchodilation.
That's a crucial distinction for patient safety and efficacy, really focusing the drug's action where it's needed most. Okay, what about the eyes? How do antagonists affect them? We use eye drops sometimes.
Right. Muscarinic receptor antagonists directly block the cholinergic responses of the pupillary sphincter muscle of the iris and also the ciliary muscle that controls the curvature of your lens. This means these agents cause two primary effects when applied to the eye. They dilate the pupil, a condition called mydriasis, and they paralyze accommodation, which is cycloplegia, rendering your eye's ability to focus on near objects temporarily useless.
So big pupils and blurry close-up vision.
Exactly. The wide pupillary dilation results in photophobia, or light sensitivity, because too much light gets in. Your lens becomes fixed for far vision, so near objects appear blurred, and objects may even appear smaller than they actually are due to the cycloplegia. The normal pupillary reflex constriction to light, or when your eyes converge, is completely abolished. These effects are most evident and intended when the agent is instilled directly into the eye as drops, which is common in ophthalmology for examinations or treatment, but they can also occur to some extent after systemic administration of drugs that cross into the eye, particularly with agents like scopolamine. Locally applied atropine produces ocular effects of considerable duration. Accommodation and pupillary reflexes may not fully recover for a surprisingly long time, sometimes 7 to 12 days.
Days, wow.
Yes, which is why other muscarinic receptor antagonists with significantly shorter durations of action, like homatropine or tropicamide, are therefore preferred as mydriatics and cycloplegics in routine ophthalmologic practice. You don't want patients visually impaired for a week after an eye exam.
Makes sense. What about eye pressure? Glaucoma.
Muscarinic receptor antagonists administered systemically generally have little effect on intraocular pressure, except in patients predisposed to a specific type called angle closure glaucoma. In these individuals, the pressure may occasionally rise dangerously because their anterior chamber is anatomically narrow, and the dilated iris can physically obstruct the outflow of aqueous humor from the eye, leading to an acute pressure spike. Muscarinic antagonists can, in fact, precipitate a first attack in unrecognized cases of this relatively rare condition. However, in patients with open-angle glaucoma, which is far more common, an acute rise in pressure is unusual, and atropine-like drugs generally can be used safely, especially if the glaucoma is being appropriately treated with other medications.
And the GI tract again, but this time with antagonists. Given how much the parasympathetic system controls digestion, this must be a major area where these drugs have effects, both wanted and unwanted.
Indeed. Our knowledge of how muscarinic agonists affect the stomach and intestine directly led to the early and once widespread use of muscarinic receptor antagonists as antispasmodic agents for various GI disorders and also to reduce gastric acid secretion in the treatment of peptic ulcer disease.
Right, blocking the rest and digest signals.
Exactly. Let's look at motility. Parasympathetic nerves generally enhance GI tone and motility and relax sphincters, aiding the passage of contents down the tract. Muscarinic antagonists inhibit this, leading to reduced tone, reduced amplitude, and frequency of peristaltic contractions. However, relatively large doses are often needed to achieve significant inhibition of motility. This is likely because the enteric nervous system, that complex network of neurons within the gut wall itself, can regulate motility somewhat independently of direct parasympathetic control. The parasympathetic nerves mainly just modulate it. So while atropine can completely abolish the effects of exogenous or administered muscarinic agonists on GI motility, interestingly, it doesn't completely inhibit all GI responses to direct vagal nerve stimulation. This difference is particularly striking for gut motility. It's likely because preganglionic vagal fibers innervating the GI tract synapse not only with postganglionic cholinergic fibers, but also with a whole network of non-cholinergic intramural neurons. These use other neurotransmitters like serotonin, dopamine, and various peptides whose effects atropine simply does not block. This makes complete inhibition of vaguely mediated motility challenging with just an anti-muscarinic drug.
Okay. What about gastric acid secretion?
Similarly, atropine only partially inhibits gastric acid secretion stimulated by vagal activity. This is because vagal stimulation of gastric secretion, a key step in acid production, is mediated not directly by ACE, but by peptidergic neurons releasing something called gastrin-releasing peptide, GRP. GRP stimulates gastrin release from G cells, and gastrin then acts directly on parietal cells and also stimulates histamine release, both of which drive acid production. Atropine will only inhibit the components of acid secretion that result directly from muscarinic stimulation of parietal cells and those histamine-secreting ECL cells, not the whole complex process triggered by vagal input. Salivary secretion, however, is particularly sensitive to inhibition by muscarinic receptor antagonists. They can completely abolish the copious watery secretion induced by parasympathetic stimulation. Your mouth becomes very dry, and swallowing and even talking may become difficult. Gastric cells secreting mucin and proteolytic enzymes seem to be more directly under vagal influence than the acid-secreting cells, and atropine can selectively decrease their function. But again, even though atropine can reduce gastric secretion, the required doses almost always cause significant effects on salivary secretion, ocular accommodation, urination, and GI motility.
Which is why they aren't used much for ulcers anymore.
Precisely. This is why more specific drugs like the histamine H2 receptor antagonists like ranitidine or famotidine, and especially the proton pump inhibitors like omeprazole, have largely replaced muscarinic antagonists for reducing acid secretion due to their superior specificity and much fewer systemic side effects. However, it's worth mentioning perinzipine again. It's a tricyclic drug, structurally similar to some antidepressants, that shows some selectivity for M1 receptors. It was found to inhibit gastric acid secretion at doses that had relatively little effect on salivation or heart rate, offering a cleaner profile for this specific purpose. It was used in Europe, Japan, and Canada for acid peptic disease, illustrating how even partial selectivity could improve a drug's utility, though it's not currently marketed in the US.
What about other smooth muscles or glands that these antagonists affect, like the bladder or sweat glands?
In the urinary tract, muscarinic antagonists decrease the normal tone and amplitude of contractions of the ureter and the bladder. They can also eliminate drug-induced enhancement of ureteral tone. This effect is therapeutically useful for conditions like overactive bladder, as we'll discuss. However, this beneficial effect is usually accompanied by those predictable side effects like reduced salivation and lacrimation, tear production, and blurred vision, making tolerability an issue, especially with non-selective agents. For the biliary tract, atropine exerts a mild antispasmodic action on the gallbladder and bile ducts, but this effect is usually not sufficient to overcome the marked spasm and increased biliary pressure that can be induced by potent pain medications like opioids. Regarding sweat glands and temperature, even small doses of atropine can significantly inhibit the activity of sweat glands, which, remember, are innervated by sympathetic cholinergic fibers. This inhibition makes the skin feel hot and dry. Sweating may be depressed enough to actually raise body temperature, especially after large doses or in high environmental temperatures. This can be particularly problematic, even dangerous, for infants and young children.
And the CNS, again. How do antagonists affect the brain? Do they calm it, stimulate it, or something else entirely? We talked about scopolamine.
Right. At therapeutic doses, atropine itself typically has minimal direct effects on the central nervous system, although a mild stimulation of parasympathetic medullary centers might occur. However, with toxic doses of atropine, central excitation becomes very prominent. This leads to symptoms like restlessness, irritability, disorientation, vivid hallucinations, or frank delirium. With still larger, often fatal doses, this initial stimulation phase is followed by profound depression, eventually leading to circulatory collapse and respiratory failure after a period of paralysis and coma.
So atropine is mostly peripheral at normal doses, but toxic centrally. What about scopolamine again?
In stark contrast to atropine, scopolamine has very prominent central effects even at low therapeutic doses. This is primarily why atropine is generally preferred over scopolamine for most purposes where CNS effects are undesirable. The basis for this difference is probably scopolamine's greater ability to permeate or cross the blood-brain barrier. In therapeutic doses, scopolamine normally causes CNS depression, which can manifest as drowsiness, amnesia, memory loss, fatigue, and dreamless sleep, often with a reduction in REM sleep. It also causes euphoria in some individuals, which unfortunately gives it a potential for abuse. The depressant amnesic effects were formerly sought when scopolamine was used as an adjunct to anesthetic agents during surgery. However, it's important to note that in the presence of severe pain, the same therapeutic doses of scopolamine can occasionally cause excitement, restlessness, hallucinations, or delirium, paradoxically resembling the toxic effects of atropine.
And motion sickness.
Scopolamine is also very effective in preventing motion sickness. This is likely achieved by blocking neural pathways leading from the vestibular apparatus in the inner ear, which senses motion, to the emetic center in the brainstem, which is responsible for triggering nausea and vomiting.
Given all these varied effects and their different chemical properties, how are these antagonist drugs processed by the body? What's their ADME like, and how does that influence their clinical use and side effects?
Right, their ADME profile is key. The belladonna alkaloids, meaning atropine and scopolamine, and the tertiary synthetic and semi-synthetic derivatives, the ones that can cross membranes easily, are generally absorbed rapidly from the GI tract when taken orally. They also efficiently enter the circulation when applied locally to mucosal surfaces, like inside the nose or mouth. Absorption from intact skin is generally limited, but notably, efficient absorption does occur in the postauricular region, right behind the ear. This is why scopolamine can be effectively delivered via a transdermal patch placed there for motion sickness.
Ah, that explains the patch placement.
Exactly. Now, crucially, systemic absorption of inhaled or orally ingested quaternary muscarinic receptor antagonists, like ipratropium and tiotropium, is very limited because of their fixed charge. These quaternary ammonium derivatives also penetrate the conjunctiva of the eye less readily when used as eye drops, and critically, central effects are lacking because they do not cross the blood-brain barrier. This is a major advantage for minimizing side effects. Atropine itself has a half-life of about 4 hours. About half the dose is eliminated by hepatic metabolism in the liver, and the rest is excreted unchanged in the urine. For those inhaled drugs like ipratropium and tiotropium, typically about 90% of the inhaled dose is actually swallowed. But because they are poorly absorbed from the GI tract, their action, when inhaled, is confined almost completely to the mouth and airways. Most of the swallowed drug simply appears unchanged in the feces. After inhalation, maximal bronchodilator responses usually develop over 30 to 90 minutes, with tiotropium typically having a slower onset of action. The effects of ipratropium last for about 4 to 6 hours, requiring multiple daily doses, while tiotropium's effects persist for a full 24 hours, making it suitable for convenient once-daily dosing for maintenance therapy in conditions like COPD.
So, summing up, what are the key therapeutic uses for muscarinic receptor antagonists? Where do we see them applied most often in medicine today?
They have been predominantly used, and are still used, to inhibit the effects of parasympathetic activity in several key organ systems: the respiratory tract for COPD, asthma, the urinary tract for overactive bladder, the GI tract, historically for ulcers, now sometimes for spasms or diarrhea, the eye for dilation during exams, and the heart in specific emergency situations. Their CNS effects have also led to their use in treating Parkinson's disease, managing the extrapyramidal side effects caused by some antipsychotic drugs, and, of course, preventing motion sickness, mainly scopolamine. The major limitation, as we've stressed, in using drugs that aren't receptor subtype selective is often the failure to achieve the desired therapeutic responses without causing those concomitant, widespread side effects. While these side effects usually are not serious or life-threatening, they can be sufficiently disturbing, like severe dry mouth or blurred vision, to significantly decrease patient compliance and adherence to therapy, especially during long-term administration. To date, achieving selectivity is mainly done by using local administration routes like pulmonary inhalation directly into the lungs or instillation in the eye, which limits systemic exposure. However, the development of those allosteric modulators that recognize unique sites on specific muscarinic receptor subtypes is currently considered a very important and exciting approach for developing truly subtype selective drugs for specific clinical conditions. This offers the promise of more targeted and tolerable therapies in the future.
Let's break down the therapeutic uses by body system again, maybe focusing on the most common or impactful applications where antagonists are really key, starting with the respiratory tract, since you just mentioned those important inhaled drugs again.
Right. For the respiratory tract, ipratropium, tiotropium, eclidinium, and meclidinium are important inhaled agents primarily used in the treatment of chronic obstructive pulmonary disease, or COPD. They work by blocking M3 receptors on airway smooth muscle, causing bronchodilation. They are generally less effective than beta agonists in most patients with asthma, but they can be useful adjuncts. When used, they are often combined with inhaled long-acting beta-2 adrenergic receptor agonists, LABAs, though the evidence for true synergism is somewhat limited. Now, there's a subtle difference. Ipratropium blocks all muscarinic receptor subtypes, including those presynaptic M2 receptors that inhibit AT release. Blocking M2 might actually counteract some of the beneficial M3 blockade by increasing local ATase levels.
Ah, the paradoxical effect again.
Potentially, yes. In contrast, tiotropium, aclidinium, and omeclidinium show some selectivity away from M2 or dissociate more slowly from M3 than from M2. This might minimize that presynaptic effect, potentially making them more effective or longer-acting bronchodilators. Ipratropium is typically administered 4 times daily via an inhaler or nebulizer. Aclidinium is used twice daily via a dry powder inhaler. Tiotropium and omeclidinium are convenient once-daily medications used for maintenance therapy via dry powder inhalers, primarily in patients with moderate to severe COPD. In normal individuals, inhaling these antimuscarinic drugs can provide virtually complete protection against bronchoconstriction produced by inhaled irritants like sulfur dioxide, ozone, or cigarette smoke. However, patients with atopic asthma or demonstrable bronchial hyperresponsiveness are generally less well protected against triggers like allergens. These drugs do cause a marked reduction in sensitivity to inhaled methacillin in asthmatic subjects, but their inhibition of responses to histamine or bradykinin is more modest, and protection against bronchoconstriction induced by things like serotonin or leukotrienes is slight. Ipratropium is also FDA approved for use in nasal inhalers for the treatment of rhinorrhea or runny nose associated with the common cold and with allergic or non-allergic perennial rhinitis. The ability of muscarinic antagonists to reduce nasopharyngeal secretions provides good symptomatic relief by drying things up. Unlike decongestants like pseudoephedrine or phenylephrine, muscarinic antagonists do not constrict blood vessels, so they are less efficacious purely as nasal decongestants, but they are good for reducing the drip.
How about the genitourinary tract? You mentioned overactive bladder. How do antagonists help there?
Right. Overactive urinary bladder, a common condition causing urinary frequency, urgency, and sometimes incontinence, can often be successfully treated with muscarinic receptor antagonists. These agents work by lowering the pressure inside the bladder, intravesicular pressure, increasing the functional bladder capacity, and reducing the frequency and intensity of bladder muscle contractions by antagonizing parasympathetic control of the detrusor muscle, primarily via M3 receptors. They may also alter bladder sensation during filling, reducing that feeling of urgency. Muscarinic antagonists can also sometimes be used to treat enuresis, bedwetting in children, particularly when increasing bladder capacity is the main objective, and to reduce urinary frequency and increase bladder capacity in patients with spastic paraplegia. The muscarinic receptor antagonists specifically indicated and most commonly used for overactive bladder are oxybutynin, tolterodine, trospium chloride, darafenacin, sulfenacin, and fesoterodine.
That's quite a few options. Are they all the same?
While some comparison trials show small but statistically significant differences in efficacy between them, the clinical relevance of these differences often remains uncertain. They all work by blocking muscarinic receptors in the bladder. The most important adverse reactions, as expected, are consequences of muscarinic receptor blockade elsewhere in the body, primarily dry mouth, xerostomia, blurred vision, and GI side effects like constipation and abdominal discomfort. CNS-related antimuscarinic effects, including drowsiness, dizziness, and confusion, can occur and are particularly problematic in elderly patients, potentially contributing to cognitive decline or falls.
Is there any way to avoid those CNS effects?
Well, CNS effects appear less likely with trospium, which is a quaternary amine and doesn't easily cross the blood-brain barrier. They also seem less likely with darafenacin and sulfenacin, as these latter two show some preference for M3 receptors, which are mainly in the bladder and glands, over M1 receptors, which are important in the CNS for memory and cognition. Unfortunately, despite these advancements towards more selective agents, these adverse effects, especially dry mouth, can significantly limit the tolerability of these drugs with continued use, often leading to patients stopping the medication. Xerostomia is probably the most common reason for discontinuation.
Can you highlight any key differences between these bladder drugs?
Sure. Oxybutynin is the oldest antagonist specifically for overactive bladder and is associated with a fairly high incidence of antimuscarinic side effects, especially dry mouth. To improve acceptance, it's marketed as a transdermal patch or a topical gel, which bypasses liver metabolism and is associated with lower side effect rates compared to the oral formulations. Tolterodine was developed to show some bladder selectivity compared to salivary glands, leading to potentially better patient acceptance. Fesoterodine is a prodrug that gets converted to the same active metabolite as tolterodines, but perhaps more reliably. Trospium, being that quaternary amine, is often better tolerated regarding CNS effects. It's unique among these drugs as it's primarily eliminated by the kidneys, requiring dosage adjustment for patients with renal impairment. Sulfenacin and darafenacin, as mentioned, show some preference for M3 receptors, which theoretically gives them a favorable efficacy to side effect ratio, particularly regarding cognitive effects. They are metabolized by liver enzymes, CYP3A4 and/or CYP226, so potential drug interactions need consideration.
You mentioned GI issues earlier with agonists. What about using antagonists for digestive problems? Are they still used much there?
Muscarinic receptor antagonists were once very widely used for managing peptic ulcers, as we discussed. While they can reduce gastric motility and acid secretion, the doses needed for significant anti-secretory effects cause those pronounced side effects like dry mouth, blurred vision, photophobia, and difficulty urinating. As a result, patient compliance was poor for long-term management. Today, the much more effective and better tolerated H2 receptor antagonists and proton pump inhibitors are clearly the drugs of choice to reduce gastric acid secretion. Muscarinic antagonists are rarely used for this purpose now. However, pirenzepine, with its limited M1 selectivity, did offer an alternative with fewer side effects and was used effectively in some countries, showing the potential benefit of subtype selectivity even back then. Various conditions involving increased GI tone or motility, like intestinal spasms or certain types of irritable bowel syndrome, IBS, are sometimes treated with belladonna alkaloids, like atropine or hyoscyamine, alone or in combination with sedatives. These drugs can reduce tone and motility, but usually only at maximally tolerated doses where side effects are prominent. Theoretically, M3 receptor preferring antagonists would be better tolerated by avoiding cardiac M2 and central M1 side effects, but you'd still expect peripheral side effects due to M3 receptor antagonism affecting salivation, bronchial function, and bladder motility. Glycopyrrolate, being that quaternary amine structurally unrelated to belladonna alkaloids, is sometimes used as an injectable agent to reduce GI tone and motility before procedures. Because it's a quaternary amine, it's less likely to cause adverse CNS effects than atropine or scopolamine. An oral solution of glycopyrrolate is also specifically indicated to reduce excessive drooling, for example, in patients with Parkinson's disease or cerebral palsy. Diarrhea associated with irritation of the lower bowel, like in mild dysenteries or diverticulitis, may sometimes respond symptomatically to atropine-like drugs, probably involving effects on both ion transport and motility. However, more severe inflammatory conditions like salmonella dysentery, ulcerative colitis, or Crohn's disease show little to no significant response. Dicyclomine hydrochloride is a weak muscarinic receptor antagonist that also seems to have some nonspecific direct spasmolytic effects on GI smooth muscle. It's occasionally used in treating diarrhea-predominant irritable bowel syndrome, IBSD, though evidence for its efficacy is somewhat limited. Hyoscyamine is also used for IBS with similar efficacy limitations.
What about using these antagonists specifically for excessive salivation or drooling? That seems like a very targeted application where drying things up would be the main goal.
Absolutely. It can be a very bothersome symptom in certain conditions. The belladonna alkaloids and their synthetic substitutes are highly effective in reducing excessive salivation, whether it's drug-induced, for example, by clozapine, or associated with heavy metal poisoning or neurological conditions like Parkinson's disease. As mentioned, glycopyrrolate, being a quaternary amine and therefore less likely to penetrate the CNS and cause cognitive side effects, has its oral solution specifically indicated to reduce chronic severe drooling. Its limited CNS effects make it a very targeted and often well-tolerated option for this specific problem.
And back to the eyes again. What do antagonists do there, specifically in ophthalmology practice? You mentioned dilation.
Right. Effects limited to the eye are achieved by topical administration, eye drops, of muscarinic receptor antagonists, primarily to produce mydriasis, pupil dilation, and cycloplegia, paralysis of the ciliary muscle, which inhibits accommodation or focusing. Cycloplegia generally requires higher concentrations or more prolonged application than mydriasis alone, and you typically can't achieve cycloplegia without causing mydriasis at the same time. Mydriasis is often necessary for a thorough examination of the retina and optic disc by an ophthalmologist. Both mydriasis and cycloplegia can be therapeutic in the treatment of conditions like iridocyclitis, inflammation inside the eye, or keratitis, corneal inflammation, by relieving muscle spasm and pain. Homatropine hydrobromide, a semi-synthetic derivative of atropine, cyclopentolate hydrochloride, and tropicamide are the most common agents used in routine ophthalmological practice for these purposes. These agents are widely preferred over topical atropine or scopolamine because they have significantly shorter durations of action, allowing patients to regain normal vision much faster, usually within hours or a day rather than many days.
What are their cardiovascular uses? You mentioned atropine in heart attacks, but are antagonists used much otherwise for the heart?
Generally, the cardiovascular effects of muscarinic receptor antagonists are of fairly limited clinical utility overall. They are typically used only in highly controlled environments like coronary care units, CCUs, for short-term interventions, or in surgical settings where precise control over cardiac function is necessary and monitoring is close. They are also sometimes used as an adjunct to cardiac stress testing to help increase heart rate in patients who have chronotropic incompetence, meaning their heart can't increase its rate sufficiently on its own in response to exercise. Atropine may be considered, as we discussed, in the initial treatment of patients with acute myocardial infarction, especially those affecting the inferior or posterior wall of the heart, where excessive vagal tone can cause problematic sinus bradycardia or AV nodal block. Sinus bradycardia is actually the most common arrhythmia seen during acute MI affecting that part of the heart. In cases of high vagal tone or developing AV block, atropine may prevent further clinical deterioration by restoring heart rate to a level sufficient to maintain adequate hemodynamic status and by eliminating the AV nodal block. However, dosing must be very judicious. Too low a dose can cause that paradoxical initial bradycardia, while excessive doses will cause tachycardia, which can be detrimental by increasing the heart's oxygen demand and potentially extending the size of the infarct. It's a fine balance.
Tricky.
Very. Atropine is also occasionally useful in reducing severe bradycardia and syncope, fainting, associated with a hyperactive carotid sinus reflex. It generally has little effect on most ventricular arrhythmias. In some patients, though, atropine may eliminate premature ventricular contractions, PVCs, if they are associated with a very slow underlying atrial rate. It may also reduce the degree of AV block when increased vagal tone is a major factor in the conduction defect, such as the second-degree AV block, Wenckebach type, that can sometimes be produced by digoxin toxicity. While truly selective M2 receptor antagonists would theoretically be very useful in blocking H-mediated bradycardia or AV block without causing other side effects, no such agents are currently available for routine clinical use. It's also worth noting that autonomic control of the heart is known to be abnormal in patients with cardiovascular disease, especially in heart failure. Patients with heart failure typically exhibit increased sympathetic tone accompanied by vagal withdrawal, both of which may contribute to disease progression. While beta blockers, which block the sympathetic side, have emerged as standard of care, less is known about whether actively augmenting vagal tone might be beneficial. Studies in animals suggested that augmenting vagal tone chronically could decrease inflammation and prevent adverse cardiac remodeling associated with heart failure. However, clinical trials of therapies aimed at doing this, like vagal nerve stimulation, have shown limited success so far.
You mentioned CNS uses earlier for antagonists like scopolamine, particularly for motion sickness and Parkinson's. Can you expand on their role in the brain?
Absolutely. The belladonna alkaloids were among the very first drugs historically used in the prevention of motion sickness. Scopolamine is generally considered the most effective of these agents for short exposures, maybe 4 to 6 hours, to severe motion, and probably for exposures lasting up to several days. A key point is that all agents for motion sickness should ideally be given prophylactically before the motion starts. They are much less effective once severe nausea or vomiting has already developed.
That's to take it before the boat trip.
Exactly. A transdermal preparation of scopolamine, that patch applied behind the ear, has been shown to be highly effective when used prophylactically. The drug is incorporated into a multi-layer adhesive unit designed to deliver about 0.5 milligrams of scopolamine steadily over 72 hours. Common side effects with the scopolamine patch include dry mouth, drowsiness is not infrequent, and blurred vision occurs in some individuals. Mydriasis and cycloplegia can also occur by inadvertent transfer of the drug residue to the eye from fingers after handling the patch. Rare but severe psychotic episodes have been reported, as have various withdrawal symptoms following abrupt discontinuation after prolonged use. Muscarinic receptor antagonists have also had a long history in the treatment of Parkinson's disease. Remember, this condition is characterized by reduced dopaminergic input into the striatum, which results in a critical imbalance between striatal muscarinic cholinergic activity, which becomes relatively overactive, and dopaminergic neurotransmission, which is deficient.
So blocking the cholinergic sign helps restore balance.
Precisely. The striatum, the major input area of the basal ganglia, contains multiple cell types, including important cholinergic interneurons, all of which express one or more muscarinic receptor subtypes. Studies using muscarinic receptor mutant mice have suggested that the beneficial effects of muscarinic antagonists in Parkinson's disease are primarily due to the blockade of M1 and M4 receptors, resulting in modulation, activation, or inhibition of specific striatal neuronal populations, helping to rebalance the circuitry. Muscarinic antagonists can be quite effective in the early stages of Parkinson's disease, particularly if tremor is the predominant symptom, and especially in younger patients. They're also commonly used to treat the extrapyramidal symptoms like dystonia, Parkinsonism, akathisia that frequently occur as side effects of treatment with conventional antipsychotic drugs. Interestingly, some antipsychotic drugs are relatively potent muscarinic receptor antagonists themselves, like clozapine or olanzapine. And perhaps partly for this reason, they tend to cause fewer extrapyramidal side effects than older agents. The muscarinic antagonists specifically used for Parkinson's disease and drug-induced extrapyramidal symptoms include benztropine mesylate, trihexyphenidyl hydrochloride, and bipyridine, though bipyridine is not marketed in the U.S. All of these are tertiary amines that readily gain access to the CNS, allowing them to exert their beneficial effects within the brain's motor circuits.
What about their use in anesthesia? You mentioned blocking reflexes.
Yes, in anesthesia, atropine is still commonly given preoperatively or intraoperatively, specifically to block cardiovascular responses to vagal reflexes that can be induced by surgical manipulation of visceral organs, especially during abdominal or thoracic surgery. These reflexes can cause sudden, severe bradycardia or even a systole, so atropine helps stabilize the heart rate during these procedures. Atropine and glycopyrrolate are also routinely used to block the unwanted parasympathomimetic effects of neostigmine, or similar anticholinesterase drugs, when neostigmine is administered at the end of surgery to reverse skeletal muscle relaxation induced by neuromuscular blocking agents.
Why block the neostigmine effects?
Because neostigmine works by increasing ACH levels everywhere, including at muscarinic receptors. This is great for restoring muscle strength at the neuromuscular junction, which uses nicotinic receptors, but it also causes unwanted muscarinic side effects like bradycardia, increased salivation, and bronchial secretions. Giving anti-muscarinic like atropine or glycopyrrolate concurrently blocks these side effects without interfering with the desired muscle recovery. Although serious cardiac arrhythmias have occasionally occurred during this reversal process, perhaps because of the initial paradoxical bradycardia sometimes produced by atropine, combined with the direct cholinergic effects of neostigmine, it requires careful administration.
And what if someone is poisoned by this anticholinesterase agents, like certain pesticides or even nerve gases? You mentioned atropine as an antidote for agonist poisoning.
Yes, it's a cornerstone of treatment for anticholinesterase poisoning as well. Large doses of atropine are used to treat poisoning by anticholinesterase organophosphorus insecticides, or nerve agents. In this situation, the poison inhibits acetylcholinesterase, leading to a massive buildup of ACOAC at all cholinergic synapses, including muscarinic ones, causing severe symptoms. Atropine works by competitively blocking the excess AC at the muscarinic receptors, thereby antagonizing the life-threatening muscarinic effects like bronchoconstriction, excessive secretions, bradycardia, and seizures. It doesn't fix the underlying enzyme inhibition, but it buys time by blocking the downstream effects. Atropine is also sometimes used to antagonize the troublesome muscarinic side effects, like diarrhea or cramping, of pyridostigmine or other anticholinesterases when these are administered chronically in the treatment of myasthenia gravis. Importantly, in this context, it does not interfere with the beneficial effects of the anticholinesterase at the skeletal neuromuscular junction, which are mediated by nicotinic receptors and are crucial for improving muscle strength in these patients. It's most useful early in myasthenia gravis therapy, before the patient develops tolerance to the muscarinic side effects of the anticholinesterase medication.
Are there any other specific therapeutic uses of antagonists worth highlighting that we haven't touched on yet? Maybe some less common ones.
Yes, a few others may be worth mentioning briefly. Methscopolamine bromide is a quaternary ammonium derivative of scopolamine. Being quaternary, it lacks the central actions of scopolamine. While it was formerly used to treat peptic ulcer disease, it's now primarily found in certain combination products intended for the temporary relief of symptoms of allergic rhinitis, sinusitis, and the common cold, mainly for its drying effect. Homatropine methylbromide is another quaternary agent, less potent than atropine as an antimuscarinic, but somewhat more potent as a ganglionic flocking agent. Formerly used for irritable bowel syndrome and peptic ulcer disease, it's now sometimes combined with the opioid hydrocodone in cough syrup formulations, though this combination must be used with extreme caution due to opioid risks. And related to sweating, sapropironium and its structural analog glycopyrrolate are both used topically for the treatment of primary axillary hyperhidrosis, which is excessive underarm sweating. Both drugs work locally to reduce sweating by inhibiting M3 receptors at the acrine sweat glands in the skin where they are applied. Sapropironium is approved in Japan as a gel, and glycopyrrolate is available in the US for topical application via a medicated cloth. This is another great example of using localized delivery to maximize effect and minimize systemic side effects for a specific problem. Glycopyrrolate, as we know, is also used systemically inhaled or oral for other indications like COPD or drooling.
We've touched on side effects throughout this deep dive, but could you give our listeners a concise summary of the main contraindications and adverse effects for these antagonists overall? Just the key takeaways.
Absolutely. Most contraindications, precautions, and adverse effects are, as we've seen, predictable consequences of muscarinic receptor blockade throughout the body. The most common ones include dry mouth, xerostomia, constipation, blurred vision due to cycloplegia, general gastrointestinal discomfort, difficulty urinating, especially in men with enlarged prostates, and importantly, cognitive impairment, confusion, memory issues, particularly in vulnerable populations like the elderly. Important contraindications to the use of systemic muscarinic antagonists include known urinary tract obstruction, like severe BPH, significant GI obstruction, like paralytic ileus, and uncontrolled narrow-angle glaucoma or a known susceptibility to attacks of it. They are also generally contraindicated or should be used with extreme caution in patients with symptomatic benign prostatic hyperplasia, as they can significantly worsen urinary retention. It's vital to remember, though, that these adverse effects and contraindications are generally of much more limited concern with muscarinic antagonists that are administered by inhalation, like for COPD, or used topically in ophthalmology as eye drops, simply due to their reduced systemic absorption and exposure. This localized delivery strategy is absolutely key to minimizing these widespread side effects.
Finally, let's discuss the toxicology of drugs with antimuscarinic properties more broadly. Because, as you hinted, it's not just the classic antagonists like atropine that can cause these anticholinergic poisoning issues, right? Many common drugs have these anticholinergic side effects that our listeners might encounter without realizing the connection.
That's a critical point for everyone to remember, as it highlights a broader clinical challenge and a source of potential harm. The deliberate or accidental ingestion of natural belladonna alkaloids from plants is still a major cause of poisonings worldwide. Moreover, many other common drugs, perhaps surprisingly to some, like certain older histamine H1 receptor antagonists, think drugs like diphenhydramine Benadryl or hydroxyzine, many phenothiazines, an older class of antipsychotics like chlorpromazine, and the tricyclic antidepressants like amitriptyline or imipramine also block muscarinic receptors to varying but often significant degrees. In sufficient dosage, or especially in overdose, these seemingly unrelated drugs can produce clinical syndromes that include many, if not all, features of classic atropine intoxication, simply due to their potent antimuscarinic activity.
So you could get atropine-like poisoning from an antidepressant overdose.
Absolutely. Among the tricyclic antidepressants, pratriptyline and amitriptyline are known to be among the most potent muscarinic receptor antagonists, with affinities for muscarinic receptors only about an order of magnitude less than that of atropine itself. Because these drugs are administered in therapeutic doses considerably higher than the effective dose of atropine, antimuscarinic side effects like dry mouth, constipation, blurred vision, and urinary retention are often observed clinically even at normal doses. Overdose with suicidal intent is also a significant danger in the population using antidepressants, and the resulting severe antimuscarinic effects contribute significantly to the toxicity and mortality. Fortunately, most of the newer antidepressants, like the SSRIs, selective serotonin reuptake inhibitors, generally have much more limited anticholinergic properties, making them considerably safer in this regard, especially in overdose. Like the tricyclic antidepressants, many of the older, typical antipsychotic drugs also have significant antimuscarinic effects. These effects are often most likely to be observed with the less potent drugs within that class, such as chlorpromazine and thioridazine, which must be given in higher doses to achieve their antipsychotic effect. Interestingly, the newer atypical antipsychotic drugs, which are generally characterized by their lower propensity for inducing extrapyramidal side effects, ironically also include agents that are themselves potent muscarinic receptor antagonists. In particular, clozapine binds to human brain muscarinic receptors with a very high affinity, and olanzapine is also a potent muscarinic receptor antagonist. Accordingly, dry mouth is a very prominent side effect of these widely used drugs. Although a paradoxical side effect sometimes seen with clozapine is actually increased salivation and drooling, possibly resulting from its complex blockade of other biogenic amine receptors, creating a confusing picture.
Who is most susceptible to this kind of poisoning?
It's vital to note that infants and young children are especially susceptible to the toxic effects of muscarinic antagonists. Cases of severe intoxication in children have resulted even from conjunctival instillation of eye drops for ophthalmic refraction or other ocular indications, where the drug can be absorbed systemically either from the nasal mucosa after traversing the nasolacrimal duct or from the GI tract if the drug is swallowed after running down the cheek. Poisoning with the combination product diphenoxylate atropine, Lomotil, used to treat diarrhea, has been extensively reported in the pediatric literature, often due to accidental ingestion or incorrect dosing. Transdermal scopolamine preparations used for motion sickness have been noted to cause toxic psychoses, especially in children and in the elderly due to their CNS effects. Serious intoxication can also occur in children who accidentally ingest berries, leaves, or seeds containing belladonna alkaloids from plants like deadly nightshade or angel's trumpet. And unfortunately, poisoning from recreational ingestion and smoking of Jimson weed, Datura stramonium, which contains high levels of atropine and scopolamine, is still seen with some frequency today, particularly among adolescents experimenting with psychoactive substances.
What does the poisoning look like? You mentioned a mnemonic.
Yes, the symptoms of high toxic doses of atropine or other potent antimuscarinics can often be remembered by the classic mnemonic. Red as a beet due to flushing from vasodilation, dry as a bone due to inhibited secretions, sweat, saliva, tears, blind as a bat due to pupillary dilation and paralysis of accommodation, hot as a firestone or hot as a hare due to inhibited sweating leading to hyperthermia, and mad as a hatter due to CNS effects like confusion, delirium, hallucinations. This pithy phrase perfectly summarizes the predictable physiological results of widespread blocking of parasympathetic innervation. A full-blown anticholinergic poisoning syndrome can last 48 hours or even longer.
How is it diagnosed and treated?
For diagnosis in a suspected case, a cautious intravenous injection of the anticholinesterase agent, physostigmine, may sometimes be used for confirmation, especially in severe cases. Physostigmine can cross the blood-brain barrier and increases HE levels. If giving physostigmine does not elicit the expected cholinergic responses like salivation, sweating, bradycardia, and intestinal hyperactivity, then intoxication with atropine or a related potent antimuscarinic agent is considered almost certain. However, physostigmine itself carries risks, especially if the diagnosis is wrong or if the patient has certain cardiac conditions, so its use is generally reserved for severe cases and under expert supervision. Depression and circulatory collapse are typically evident only in severe intoxication. Blood pressure declines, convulsions may ensue, respiration becomes inadequate, and death due to respiratory failure may follow after a period of paralysis and coma if supportive care is not provided. If the poison has been taken orally, measures to limit intestinal absorption, like activated charcoal, should be initiated without delay if appropriate. For symptomatic treatment of severe anticholinergic delirium or coma, slow intravenous injection of physostigmine can rapidly abolish these central effects, but it requires careful titration and monitoring as it carries some risk of causing cholinergic crisis, too much H effect, or seizures if given too quickly or in the wrong patient. Because physostigmine is metabolized relatively rapidly, the patient may lapse back into coma within 1 to 2 hours after a dose, and repeated doses may be needed. If marked excitement or convulsions are present and more specific treatment with physostigmine is not deemed appropriate or available, a benzodiazepine, like lorazepam or diazepam, is generally the most suitable agent for sedation and for control of convulsions. Crucially, phenothiazines or other agents with significant antimuscarinic activity themselves should not be used because their own antimuscarinic action is likely to intensify the toxicity. Supportive care is paramount. This includes supportive respiration, mechanical ventilation if needed, and aggressive control of hyperthermia, using cooling measures like ice packs and alcohol sponges, which may be particularly necessary, especially in children. #outro.
Wow, that was a truly comprehensive deep dive into the world of muscarinic receptors, agonists, and antagonists. I feel like we really covered the landscape. From the intricate dance of G proteins inside the cell, to the ingenious ways drugs can be designed for specificity, like those allosteric modulators, and the profound effects these substances have on virtually every system in your body.
Yeah.
It's incredibly clear how foundational this knowledge is, especially for anyone wanting to truly master pharmacology.
It really does highlight the elegant complexity of our own biology, doesn't it? And how even subtle chemical changes can steer a drug toward vastly different outcomes. Therapeutic benefits in one case, toxicity in another. We've seen how understanding receptor subtypes and even exploiting those secondary allosteric binding sites is unlocking genuinely new possibilities for highly targeted therapies that might minimize those unwanted side effects. It's a truly exciting frontier in drug development.
And for you, the listener, I hope this deep dive leaves you with not just a mastery of these specific concepts, but perhaps a deeper appreciation for the sheer ingenuity required in pharmacology. When you next encounter a medication, whether it's something seemingly simple for motion sickness or something for asthma or an overactive bladder, or maybe even a complex psychiatric condition, you now have a much clearer picture, I hope, of the molecular machinery it's interacting with and the delicate balance it's trying to achieve within your body.
Indeed. And this raises an important, maybe thought-provoking question for you to ponder as we wrap up. As we continue to uncover more about the nuances of receptor function, particularly through these advanced techniques like cryo-electron microscopy that give us atomic-level views, and through the continued development of even more sophisticated allosteric modulators, What other previously untreatable or perhaps difficult to manage conditions might become amenable to highly selective muscarinic targeted therapies in the future? The possibilities are still unfolding, and that's what makes this field so dynamic and hopeful.
What a great thought-provoking way to end. Thank you for joining us on this deep dive.